Hello, class. Now it's time for our global healthcare panel. We are very, very fortunate to have some people that I consider to be great colleagues from around the world. So we're going to start with letting our representative from the United Kingdom introduce herself and where she's at and what she does, those types of things like that. Vikki?
Hi, it's great to be here today. So my name's Dr. Vikki Park, and I work in a university called Northumbria University. That's in the northeast of England. So if anyone's familiar with Vera, the show, I'm an honorary Geordie today, so it's an absolute pleasure to be here. I know Tony's a big fan of Vera, which is why I mention it. So I'm from England and I'm an assistant professor of nursing, but also for interprofessional education and collaborative practice. So a lot of the work that I do is leading interprofessional education advancements, lots of scholarly writing and publication, but also teaching right across different health professional programs, which I've done for quite a long time now. So it's lovely to be here today.
Good. Thank you very much, Vikki. Now our friend from Germany, Doreen.
Yes, thanks for the invitation, Tony. It's a pleasure to be here today. So who am I? I'm basically Doreen Herinek, which is obvious. I'm from Germany and representing the professions of physiotherapists. So basically I'm trained as a physio, but afterwards I've done my studies in health sciences as a bachelor degree. Afterwards, a master's in health professions education. And since 2016, I'm now working in research and trying to write my PhD since 2020 in interprofessional education, especially with a focus on peer-assisted learning. So how should tutors be trained to become good tutors, if you like, so in mono or uni-professional as well as in interprofessional context. So my daily work is at the university, not so much in practice. So I'm not working in a clinical context anymore, but in a theoretical context. So I'm doing teaching in our 2 study programs in the Bachelor of Health Sciences and the Master of Health Professions Education with a focus on educational research and how our health professionals in Germany are trained. So more the laws and regulatories about this very, very difficult topic for my students. I'm supervising masters and bachelor theses, doing publications and networking.
Wonderful. And speaking of that, both of you and I work together on some committees, and it's great to work with you both. So, okay, Vikki, describe the healthcare system in the UK, kind of its background. How do people pay for healthcare, and how do people access, healthcare? What type of different providers do they see?
So I'm sure you've heard of the NHS. I think most people have. It's the 5th biggest employer in the whole entire world. So I think that's why most people have probably heard of it. So the National Health Service turned 75 this year. So when we get to July, I think we should have a party. We celebrated its 70th birthday, but I don't think we've any plans for its 75th.
Well, that means its birthday was 1948, correct?
1948, exactly. So there was a bill passed through Parliament in 1946, and 2 years later, this was actually launched. It's obviously evolved a lot in those 75 years, and it was based on a couple of principles, but the biggest principle really was equality. And it was introduced as a way of making sure that anybody could access healthcare, irrespective of whether you could pay for it or not. So that was the principle behind it at the time. And I think if we look at the timeline as well and what was happening in England in that time, loads of countries around the world were all recovering from the war. So thinking about what was happening in terms of infrastructure, the world was in a bit of a mess, wasn't it, really, at that point in time? There was a lot to recover from. So the NHS was introduced as a way of improving health, and at the time, not social care. So the way that the NHS looks now is it is a government-funded system. And what that means is people like me get taxed hefty amounts from our salaries, and it's funded principally through taxation and also through national insurance contributions as well, which we pay on a monthly basis. So in terms of the way that it works, in the United Kingdom, we've got 4 nations. And the way the NHS runs now, it's been devolved to each of those nations. So it's interesting when we think about the way our countries are all structured. We've got about 67 million people at the moment in the UK. And thinking about the population for Missouri, which is sitting around about 6 million, it gives you an idea of how big the UK is. And in terms of the way the population's split, as you would expect, the majority of people are in England. So I think we're sitting about 58 million in England alone. And the decisions that are made in each of those nations are made by those governments. So there's often, you get to a border between countries. So you get up to Northumberland, you step into Scotland, and it can be a very different experience just going a couple of miles up the road. So it does make it very interesting in terms of regulations and how systems run. And the NHS isn't completely free. So for example, prescriptions at the moment, the cost for a prescription for one item at the minute, I think I'd looked at it last night, was £9.35. That's the equivalent of about $11 American dollars for one item. So there are charges, it's not completely free. Dental costs can apply, optician costs can apply. So there are actually costs attached to certain types of treatment. It's not completely free. But if I was to walk into hospital and have a baby, for example, I wouldn't be given a bill at the end of that. That's completely paid for. So by and large, it's a free service to the people in the country at the point of provision. And I've got a couple of figures, which I guess would be quite interesting to share. So social care, 26 billion spent on adult social care last year, which is obviously an awful lot of money. The NHS actually, every 36 hours, the NHS has seen about 1 million people every 36 hours, which gives you an idea of how many people are accessing the NHS. And
does that, excuse me, Vikki, does that have to do with kind of the recommendations around care models? As far as primary care and those types of things like that?
Which bit, Tony? Which bit,
as far as the number of people that the NHS sees, do you think that's a function of kind of the focus that the NHS has on primary care?
I think it's really interesting the way that it's set up in England, particularly because up until recently, social care has just become part of the Department of Health. It used to be Department of Health and had been for a very long time. And now it's the Department of Health and social care. And I think what's really interesting is in terms of health, we think about health as being GP practices, so doctors' clinics, hospitals, those types of provisions. But we think about social care, and social care is not funded that way. It's funded by local authorities and it's means tested as well. So if I was to go into a nursing home, for example, then there are certain thresholds where, because you're mean tested, you may have to pay for the whole entire cost of that social care support that you get in a nursing home, or you may pay partial, or if you don't, I think it's less than £14,000, then you don't have to pay anything. So social care and health are set up quite separately. And Department of Health and Social Care spent 192 billion in 2020 to 21. So it's huge business, huge revenue. And at the moment, it's still set up quite separately, trying to bring things together and trying to make things more seamless in terms of the continuity of care. It's an interesting setup.
Yeah, very interesting, very interesting. So let's turn it over to Doreen and talk a little bit about kind of the healthcare system in Germany, and kind of how it gets paid for, how people access care, those types of things like that.
Yes. First, I need to add one information about myself because I forgot my institution. I'm working at the Charité, Universitätsmedizin Berlin. So sitting in the capital right now. But with regard to our system, I can hear some similarities to the UK, to be honest. So maybe the basic information first. We have a very, very general practitioner-centered system. So everybody can choose a general practitioner close to where they live. So you can, in case of illness or you got a cough, you needn't to go to a hospital, but you go to your general practitioner. I will come back to this later. But the general practitioner makes all the decisions on your treatment. So if he or she thinks you need some, I don't know, specialist treatment, he can write or she can write the proposal or referral for it, as well as for the physio or the hospital. So if you need further treatment, he or she has to make the decisions. In Germany, we have 5 basic principles which apply to the whole health system in Germany, which is at first the compulsory, yeah, that word is really difficult in English for me.
Compulsory?
Yes, compulsory insurance. So everyone has to be insured by law since 2007. And it's a divided system. So we have a statutory health insurance, which are the main focus, or which is the main focus in Germany. So 90% of our population are insured by statutory health insurance and only 10 by private insurance. So I will focus on the statutory health insurance because it's the main thing here. And the payment for this insurance is monthly and currently at 14.6%. And it's divided. So the half of it is on the employer's side, and the employer has to pay 7.3%, and the other half is paid by the employee. So the other 7.3% are directly transferred from your gross salary. So your health insurance gets the money from you every month. And as you can imagine, every insurance has different population in it. So we have a lot of insurances, not only one, but more than 100 different insurances in Germany, which makes the problem obvious. So they collect all the money, and all the insurances need to transfer the money to a so-called health fund. So all the insurances put the money into a big hop, if you like. And the hop is again transferred back to the insurances, but then with regard to the population they insure. So if there is one insurance with a lot of ill people, for example, and one with a lot of healthy people, the one with the more ill people gets more money than the other one. So this is really some kind of fair system. And this is called the morbidity-related risk structure compensation. A really difficult thing, but quite fair. So this is the main thing in Germany. We have, of course, if you have heard, the contribution financing. So if you go to a doctor or to a hospital, it's free, but it's the same like in the UK for dental services, or for example, for physiotherapists, you need to pay a small amount of additional fee or charge. It's not completely free, but if you go to your general practitioner, it's totally free because you pay every month your insurance. So not out of pocket, but somehow an indirect thing. So not money against treatment, but yeah, you know, you pay the insurance and then you get your treatment. And the fifth principle, which is very important, is a self-administration principle. That means that in Germany, of course, the state provides us with laws in a wider range, but the main decisions are made through the health system players themselves. So we have what is it called? A regulatory body, let's call it that way, which covers, of course, physicians, the insurances, and some patients. So no nurses, no others, but these groups, and they negotiate which treatments should be offered to the population in Germany and things like that. Yeah, I think that's a main thing in Germany. Very briefly.
So a couple quick things about your presentation is, one of the key things in Germany is that they put the money into through these sickness funds, and then use that pool to spread the risk out amongst the population. So for example, if one community is all coal miners, for example, they're going to have a lot more sickness and disease than maybe
Yeah.
a younger population of college students. So
Yeah.
so they use that to kind of spread the risk out to keep the cost down for everyone.
Yes.
And it needs government to be involved with that. Otherwise, there's
Yeah.
no way you could negotiate it between the
because-
different groups.
Yeah, because you can choose, every citizen can choose his or her insurance. So of course you have insurances who have people gaining a lot of money and such with a lot of illness and not gaining so much money, and they try to somehow negotiate that somehow fairly. I don't know if this is the right word, but yeah.
No, that's good. That's a good principle. And you can definitely tell the differences between the NHS is really basically a truly government managed plan, whereas Germany has these separate insurance companies, but it's all kind of regulated by the federal government. So
Yeah.
that's interesting. Okay, and as we know, we learned in class, the beverage model is in the UK and the Bismarck model is in Germany. So I just remind the students that. Okay, so Vikki, talk to us about, if you think about the NHS, what are some advantages of the system? When you talk to somebody, like maybe from another country or something where, what do you think are the real things that you like about the NHS? And what are some things that if you had a chance to change them or just kind of, it's a disadvantage that's kind of baked in? What do you think applies to your health plan?
So I think I'm getting some new thoughts actually by talking as a group today, which is really interesting, because what we also have, not only do we have the 4 nations, but if I look at England alone, which is obviously the country that I'm in, and it's got the largest population, what we also have is we have what's known as a north-south divide. And what's meant by that is in terms of people's health, in terms of their economy, in terms of their wealth and income, there's a huge gap between people who are living down south. So for example, in the area of London, whose life expectancy is higher and some of the complex conditions that have lots of comorbidities attached are lower in areas like that in London compared to where I am in the northeast of England. So even in a small country like England, which only has kind of 60 million, you've got this recognised long-standing gap between the health and wealth of people based on where they live. And in terms of organising health provision as well for people, it's in the past been referred to as a postcode lottery. So we have postcodes, not kind of zip codes or that sort of thing. And what that refers to is that the way that healthcare is provided, sometimes it depends where you live in terms of what treatment you can get access to. And that raises questions about quality. So that's brand new information that's just come into my head, just listening to Doreen talking. And I suppose what we've also got is we've also got private healthcare provision as well. So we have really long established companies like, the Nuffield and Bupa. And so we also have private healthcare schemes within the United Kingdom. So it is more complex than it would appear. Just thinking about the NHS, it's not free. In that system, you do pay for things. There's a private provision, there's difference in the provision and allocation of treatments and care. And one of the moves that we've just made very, very recently, and again, this got pushed through Parliament, was to move to something called integrated care systems. So that's new as of last year, and that just got pushed through Parliament. And what that means is they've split the country into regions. And these regions are now responsible. They have boards, they have ICBs, integrated care boards, and these boards are responsible for looking at the provision of health and social care across their area. So the area I'm in, being a Geordie and straddling that northern border, means that we actually go from the west coast of England to the east coast in a strip right across, which is a huge geographical area, from Cumbria right across to kind of the northeastern Whitley Bay and the coast. So we run right across that stretch of England. And that ICB will be responsible for looking at costing, the allocation of funds. And the whole attempt at doing this is to try and make care more integrated, so people have more localised control over how spending occurs. It's to try and diminish this postcode lottery It's to try and get professions working together more effectively and more cohesively as a team. I think some of the other benefits definitely to talk about would be the life expectancy. So that's shot up. That's shot up by, I think, 13 years now for both male and females since 1948. But in the same token, it's almost a victim of its own success. We've now got people living longer, and what that means is putting more demand on the health and social care setting than ever before, because people are living longer than they've ever lived, and that's because the NHS has kept them going, basically.
Yeah.
And there's also different ways of accessing healthcare. We've got telephone lines, we've got online services. You know, the world's moved on in terms of NHS. And I think what's really interesting to look at is when you start looking at statistics and comparing them, things like stroke and heart disease, interestingly, have halved. But in 2007, we had a legislative smoking ban, which makes you wonder whether it's been the NHS that's done that or whether it's been this legal, you're not allowed to smoke in public now in England. So it's an interesting situation. You may have seen headlines recently where a lot of our workforce are currently on strike, and they're on strike because they want better working conditions, they want, you know, better pay, want to have more provision, more equipment. So there's a lot of post-pandemic issues that we're working through, huge backlogs of patients, giant waiting lists, staff, it's all going on over here, staff strikes. It's a very interesting time, I think, in our healthcare at the minute. It's a bit of a mixed bag, Tony. I think that's the key message.
And I think that's kind of the way it is everywhere. I think every place has advantages and disadvantages. So Doreen, talk to us about, when you think about the German healthcare system, think about what do you feel is really, really good about it, and what are some things that could get better?
I think there are more disadvantages than advantages, unfortunately. But to name some, I think, as I've already mentioned, it's a real fair system. So everyone can access healthcare if he or she likes it. It's, yeah, even if you earn somehow too much money, there's a limit. So how can I call it? The 7.3% I've mentioned, this is only up to a certain amount of money. So there's some kind of stop. So if you earn too much, you needn't to pay much more than the others. So it's somehow fair and unfair. You can see it from two sides of the coin. I think it's good that we can have the free access to healthcare. We have a lot of physiotherapists and offers in primary care, although we have a hospital-centered system, in my opinion. This is my personal opinion. And yes, I think there's always a possibility to get good healthcare from experts. And in comparison to other countries, I think the waiting times are not too bad. I think the discussion in Germany looks differently from that statement, but in comparison to others, it's not too bad. And I think on the one hand, it's also good to have a first contact person. Yeah, that's it. Okay,
so you think about, this is one of the things we talk about in this class is the cultural influences on some of these decisions, right? You know, in Germany is a culture that thrives on structure, laws, all those types of things like that. Whereas the UK, there's a lot more of kind of a groundswell of kind of the House of Commons, kind of the people can say what they want when they want, and those types of things. And I think it's and you can start to get a feel for how the culture has kind of fashioned these systems, which is really, really interesting. So to wrap up, your information's been outstanding. I'm going to give you a chance to say a few things about, generally, not just in your country or in your area, what needs to happen in your area and worldwide in society to improve healthcare. what are some keys to, for the next decade or 20 years that could really make the difference in the health of persons and the health of communities and those kind of things? Vikki, what do you think?
Okay, so I gave this a bit of thought. I've come up with 3 things. I'm going to tell you about these 3 things. So the first thing I'm going to call waste management. The second thing I'll talk about is interprofessional education, collaborative practice. There's a surprise. And the last thing to mention, I think, for me, is about how we value each other. So the first thing to talk about in terms of waste management, which might sound quite a strange thing to start talking about. So about 20 years ago, give or take, I spent a bit of time in Liberia, which is in the west of Africa. Now, they weren't that long out of a civil war. And I went out there with a charitable organisation and actually spent some time, believe it or not, on a floating ship docked in the harbour, working in their theatre, their onboard hospital theatre suite. And we were doing operations for people who couldn't afford them because their health system was nigh on non-existent. So this was a hospital ship that was there to perform surgeries for people in Liberia who couldn't afford that. Now, as you can imagine, you're on a ship, you can't just get an order delivered. So that meant the practices that I was used to, getting access to single-use equipment, at the time, 20 years ago, that was not available. So they were so effective and resourceful with what they had because they had so little. And I spent that time doing things like, we used to bleach masks, for example. We couldn't just go to the cupboard and get an oxygen mask. That wasn't there. So we had to disinfect everything, sterilize everything, and it was all done on the ship. So when I'd come back to the United Kingdom and started working in an adult critical care environment, I was absolutely horrified at the sheer waste by contrast. And it became so apparent to me how much money we were wasting on a daily basis in terms of equipment, how much waste we were generating. The infection control rates were fantastic on the ship. We didn't have a high infection risk at all. And what that did to me was shone a huge light on there are other ways to work and we can work more effectively. And I think one of the things that all countries talk about is how expensive it is to have health and social care. So thinking differently about our day-to-day practices, how we use equipment, how we acquire things, how much things cost, that was a huge eye-opener for me. And I think if everybody had that experience, I don't think we'd be working the way we are now across the world. I think it would be very, very different. I think we're very privileged in countries like England when we just spend money and expect equipment to be there. We go to a cupboard and we just expect to put our hands on things. So I think we're very privileged in the way that we work. And I think that makes us by proxy wasteful. So that's one of the things I think that the world could look at in terms of sustainability, waste, plastic use, all that sort of stuff, which is really very important. So that was an interesting one to kick off with, because that was such a huge eye-opener for me personally all those years ago. In terms of teams working together, the World Health Organization has been advocating this for decades, and you're highly unlikely to find anybody who will oppose the opinion that when you work together, you work better and you work more seamlessly. So I do think that interprofessional education and collaborative practice is absolutely key in terms of, again, looking at the way that we work, working smarter and not harder, thinking about the way we assess people, reducing duplication in what we do, shared decision making, just making the services that we give more humanized, but also more effective. So I think for me, if I could just get a magic wand and just sprinkle IPE CP dust all over the world, and I think that's what I would really love to do. And then I think the final thing brings us back to that core concept of kindness and what it is to be human. So again, if I got that magic wand out, I think what I would absolutely really love to say is this idea of creating a circle of safety within the teams that we work in, so that there's that psychological safety to ask questions, to learn from each other, where there's professionally used humor so that you get joy in your work. It's a safe place. It's a place you want to be. You actually get fulfillment from your role. And that comes from gratitude. It comes from kindness. It comes from compassion, and it comes from respect. And it doesn't matter how much money you throw at a service. You can't get any of those things by throwing money at a situation. And this comes down to culture and how we work and respect each other as a profession going forward. So they would be, I think, if I could change the world, they would be, I think, the three things that I would love to see in my lifetime.
Eloquent as always, Vikki. Thank you very much. How about you, Doreen? If you took went over and grabbed Vikki's magic wand and started waving it, what do you what would you hope to do with the healthcare system and health and those types of things?
Yeah, first speaking for my region, it would be one citizen insurance for all. So not the division into the private one and the other one, to reduce bureaucracy. A lot of bureaucracy and competition. So it's really stupid to have more than 100 insurances doing all the same. I don't know for what. So that would be the first thing in Germany. I think the second is not only for Germany, but also for a few other countries. That is, do not put the focus too much on doctors. So doctors are key. This is of course the case, but too much doctor-centeredness is not good, because speaking for Germany, nurses and other professions are totally underestimated. They have no power, they are nothing. So even the population says, I need to go to the doctor. So if there would be a nurse as a first contact person, that wouldn't work, because the population wouldn't trust them or trust their competencies. So this is really, I think, somehow sad, because they could do the same job as doctors, and physicians would be could be able to do much more work they should do, instead of bureaucracy or questioning people, things like that. So that's really one thing. And accordingly to this, the qualification of the health professional should be updated or renewed or reformed. So in our country, only physicians are trained at the academic level. So the nurses and PTs, OTs, speech and language are not. So we have some kind of vocational training, which is so much lower than the physicians are. So that's for me, or in my opinion, this is a real fault in the system, which underlines the underestimations from the population, because this one group has studied 6 years, the others has only training for 3 years. And so this is, continuing. Yeah, and the last thing is definitely the point Vikki already mentioned, and it was IPE and IPC must be strengthened and funded. So it's not about the goodwill and the hard thing, but the state needs to make laws in Germany, of course. We need the regulation for it, and not only the good-willing people doing IPE and interprofessional collaboration, and not only interprofessional collaboration in Germany, but also among physicians and the others. Yeah, the hierarchy thing, which is mentioned in the Be Human part from Vikki, and value each other. And of course, the global networks should learn from each other, so best practices. And there is so much work done in the last years, so we should just use it. We can take it, but there needs to be open-minded politicians. And so probably in Germany, we need to change the politicians.
So, and actually in the remaining part of this class, we're really focusing on policy change, like how our students can get involved in helping change policy and those types of things like that. So
they are the change agents for the future. So
this is wonderful. Thank you so much, Vikki. Thank you so much, Doreen. It is great seeing you, and it's evening where you are at. So enjoy the rest of your afternoon and evening, and thank you very much. I appreciate it.
Thank you.
Always a pleasure. Good luck with your studies, everyone.
Thank you.
Thanks.
How about going to go now? So now we have the distinct pleasure of having Dr. John Gilbert from Canada going to talk to us about the system there. Dr. Gilbert, can you tell us a little bit about your background and what you do?
Well, I've been a professor emeritus at the University of British Columbia for the last 17 years. So I guess what I do is that I am an active, retired, but not retired person from academics. My history is a long one, so I won't bore you with that, but I have been engaged in policy making around health and health education for a very long time. My role at the University of British Columbia was originally to start the School of Audiology and Speech Sciences, which is another long story. But essentially, my life is about policy. It's about how do we make policies that can effect changes in health and social care education. I have been associated with interprofessional education for person-centered collaborative practice for more than 45, 50 years. And I like to think of myself as kind of, one of the grandfathers, or even one grandfather of this field, along with people like Hugh Barr in England, Maddie Schmidt in the United States, and Bud Baldwin. There was a cohort of us who were right there at the beginning of the world.
Yeah. I prefer to call you my nice uncle instead of a grandfather.
So it's a very long history, and it's been Tony, it's been a wonderful history, and I've been very fortunate. I live in a very well-developed country. We have a very solid system of government. We have been long-time peacekeeper. We share our values with many different countries, including our healthcare values. And as we share those, we try to assure the world that Canada is there for them. And I'm very proud of that. I am an immigrant. I came to Canada more than 56 years ago. And it's my great privilege to actually sit and welcome. I preside at Citizenship Court, and I welcome new Canadians. I've welcomed 300 so far this week and do another 100 again tomorrow.
Wow.
So, it's a kind of different background in some senses.
Yeah, no, you've definitely accomplished a lot. And what's really cool about this class is that the remaining part of the class is we are going to focus on system improvement and policy change. And so,
Right.
I think it aligns very closely with some of the things you're interested in. So can you talk about the health system in Canada, kind of how it's funded, how it came about, how people access care in Canada?
Yes, well, until 1968, Canada's healthcare system was a private system. It was essentially, a single, you paid as a patient, you got insurance, and if you didn't have insurance, then tough, you suffered. But we had a wonderful socialist, can I use that word? MP in Ottawa from the New Democratic Party, as it was called then, who moved the notion of universal health care at point of entry, free to the consumer, so that in 1968, we saw the development of our national healthcare system. And the healthcare system essentially was set up to ensure that people regarded health not as a privilege, but a right, very important concept, that it didn't matter how rich you were or how poor you were, the healthcare system would provide for you. There have been many iterations, changes in the system since that time, but fundamentally it remains the same. It is a right, not a privilege, and everybody pays through their taxes in order that everybody benefits from this system. I don't know if you know, but Canada has a population of about 38 million people, spread across 4.5 time zones in 11 provinces and 2 territories. And the organization of healthcare essentially is at the provincial level. Okay, so the federal government passes the major legislation, but every province and territory has legislation which deals with its specific issues. So Quebec is a different place from British Columbia or from Nova Scotia. So the provinces receive from the federal government every year an amount of money which is put into their budget in order that they can improve, increase, develop the care which is being provided at the provincial level. But essentially, as I said, the provinces are responsible for ensuring that ideal of healthcare is delivered at the provincial level. The issues are very similar to those around the world in terms of what it is we're trying to do for the patient. I've been lots of places, Tony, and it doesn't really matter where you go. Fundamentally, the structure is how do we provide the best possible care with the best possible means, et cetera, et cetera. So there are places now where not everything is publicly funded because the government saw a way of not really building and building and building a healthcare system with more and more people in it that really becomes very expensive. We spend federally, that is Canada spends every year about 11.5% of its budget on health. But at the provincial level, provincial budgets, it can be like 45% of their budget goes on health. So that's a big eat, right? So what has happened is that procedures, the provision of testing for disease, et cetera, so the lab kind of work, that has been not privatized. It's been given to a big company that in fact bills the system, bills the government for what it is providing. And that, of course, we pay for in our taxes. And now a fair amount of things like regular scanning takes place in a private sector, but again, that sector bills the government for what it does. You don't pay as a patient, the government pays that because it wants to get it out of the acute care sector, because otherwise we'd have queues and queues and queues of people. So about 30% of the system, at least provincially in British Columbia, 30% of the system is in this quasi-private mode, private in as much as these places are set up, but essentially the government's still paying. And there's a big fight to ensure that that kind of system continues, because we have looked south of the border. We're not happy with what we see in the healthcare system south of the border, but then I suspect there's maybe goes in the other direction as well. And there's a huge opposition to any kind of insurance system being put in place to replace the public system. But you can, in fact, buy insurance to provide you with more athletic support or more physiotherapy, or because the government only provides for physiotherapy in my province, it'll pay for 12 sessions a year. So if you want more, then you go and you buy insurance and et cetera. But that's not hugely popular at the present time. I mean, not many people do that. So we have this kind of interesting system, right?
Yeah, so athletic therapists, my colleagues, they do a lot of cash-based business. They do a lot of, they keep the price point down, and people just prefer to, instead of taking out that other insurance, they just pay cash that way. So what do you feel that are, when you talk about the system in Canada, what do you really feel are the big advantages? So when you, not only compared to the US, but also places like the UK with NHS and elsewhere, what do you really feel that are the advantages, and where some areas where things could get better?
Well, the advantage is that we do regard it as a right. I mean, that's a huge advantage, because that changes every policy initiative that's put in place. If you say you have a right to health, then you've got to really work hard on making sure that all policies enacted address that particular right. So that's fundamental. But I think that given the way in which the federal government is responsible for example, criminal justice. So anything that's criminal is associated with the federal government. What that means is that Health Canada, which is in Ottawa, is responsible for some national health programs, which I think is also an advantage. So occupational and environmental health. The regulations and policies for that is made federally, okay? Because that's not a healthcare, it's not a direct healthcare issue. And that's really, really important because you wouldn't want 10 different, approaches to occupational environmental health. So you want that federal system. The federal government is responsible, chiefly responsible for health promotion. So it has big health promotion programs. But then it kind of filters those down to the provinces. And it's a huge advantage for there to be a common set of principles around health promotion, which are then shared across the country, but people agree on because it goes through Health Canada. Health protection, another, safety issues, that's a federal responsibility because as you can see, as I said earlier, it can become a criminal problem. Health protection, safety, really, 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 really very important. And I think those are major advantages. I mean, when you have policy that can be, and I should tell you, because I suspect you know this, Tony, but we are a consensus country. Nothing works if it isn't by consensus. So these issues are always addressed consensually. So I've been on, federal, provincial, territorial committees where we've, wrestled with the East Coast versus the West Coast versus the coast in the North around issues that if we didn't reach consensus, no policy was made. It's only with consensus. So I guess that's an amazing
concept.
That's the Canadian that
Exactly.
Everybody says Canada's so boring, and I say let's keep it that way because
Exactly.
people work on consensus. So yeah,
Exactly.
so those are the advantages: fundamental right, and then certain issues which are addressed federally because then they can be distributed provincially.
So, what are some issues with the system in Canada? I've heard there's, you hear waiting times all the time. How does that manifest itself in the actual boots on the ground system?
Yeah. So for 6 years, I served on the provincial, the BC Patient Safety and Quality Council, an absolutely incredible experience and one from which I learned a lot. Show me any country which does not have a wait list problem. Show me any country. And you can't just say, oh, Canada, you have a wait list problem. I could show you any place. Why? Because if you're lined up for surgery and it's not essential surgery, and somebody has to be scraped up off the road and go into surgery, you have a wait list problem, right? Because that person is going to get ahead of you regardless, because somebody's putting them back together again. And your surgery is maybe not critical. So, knees, hips, shoulders, those are not seen as critical issues. So you go into a queue. And we've worked out, and certainly in British Columbia, we worked out a very good system addressing the waitlist issue. It's access, we're always talking about, but it doesn't matter how hard you work at it, there will always be this kind of 12, 13% issue around having to wait. So I'll give you an example. Yesterday, I was out doing something that I enjoy doing on a Tuesday afternoon, which is lawn bowling indoors. And I was asking a guy, oh, you don't look very comfortable today. He said, oh yeah, I have to have knee surgery. I said, oh, where are you on the list? He says, well, probably about 8 months. And he wasn't concerned, he's on a wait list and that's it. But things like cancer, that's critical. And we do have a little problem, and not huge, but we do have a little problem. If you are diagnosed with, say, melanoma or something on the skin, you want to be sure you can get and see somebody. So that is a little issue. The big issue is the one that you have, Tony, in the United States, which is drug prescriptions. We've tried very hard to have a a policy around the funding of prescriptions federally, which would be a huge addition to the national health system. But you know what got in there that pushed it? As we were all ready to put this in place. What got in there and pushed it aside was COVID, because when COVID came in, we had huge numbers of women as as childcare, et cetera, and say we have to have childcare. We can't. So the government shifted its policy to looking at providing funding for childcare, which of course pushed that prescription thing totally off the radar. But that is an issue, and although in my province, and I think it's true in most provinces now, we do have very strict regulation about prescribing. You have to prescribe the lowest cost similar drug if you're a physician, and if you oversubscribe, that is tracked. And you are called before the College of Family Physicians or College of Physicians and Surgeons to explain your behavior if you're overprescribing. So it's a big issue. But show me any country that doesn't have that problem.
Yeah, no, it's a big issue here for sure. So so to wrap it up, tell us if you had a few things that you wish for or you feel that it's important to emphasize within the healthcare system. If you could, I believe Vikki was waving her magic wand. If you had a hold of that magic wand, what are some things that you would like to see moving forward with the healthcare system?
I certainly like to. I think we need to address the inequities. There are inequities in the system, and we need to do something about it. And we are working on it, but the inequities are both federal and provincial, and certainly territorial. And like the territories are those places in the extreme north of the country, and so inequity. Elderly citizens, everybody's talking about this now, right? If I could wave a magic wand, I'd try to solve that one tomorrow. We never will, but we have to have much better procedures in place, and we've seen that with the incredible number of deaths in extended care facilities, et cetera, as a result of COVID. So we have to put a lot more emphasis on that particular population. And being a member of the elder population, I am not concerned about me, but anyway, the system-wide rising costs, we have to get economists really engaged. I think the problem, Tony, is so difficult that economists, they just don't want to look at it. Now it's easier in a system maybe like the United States, where the economists can look at a lot of specific things in the private system, but we don't have that. And we really have to look at those rising costs, because when the healthcare costs rise, it means the money has to come from somewhere else: bridges, buildings, schools, et cetera. Satisfaction, we're still not clear about whether our citizenry, because we are citizens of Canada, we're not subjects of the king. We're citizens. We have to be sure that people are satisfied with the care they're getting, or the health, what we're trying to do to improve, health generally. And we're not sure. And in the absence of that kind of information, how do you change the system? All right. And then cost containment it's closely associated with that in global budgeting, because when we don't have cost containment, you get a huge input of new technologies. We've got to have the latest, whatever. And that means that the percent of the population which require a huge amount of our attention, mental health problem, 80% of our problem, 20% of our expenditure, huge issue. So these are things about a magic wand I'd like to.
Yeah, it sounds like the triple aim. You and Don Berwick must have lunch. So if you have one parting thing to say regarding mindset for health professionals moving forward, do you have something quick you could say to our class about something to think about as they embark on their career as health professionals?
Yeah. I'm going to illustrate in a funny way, but we've looked at the the kind of program entries that universities put in their catalogs around each of the health and social care professions. Not one of them, as far as we can see, says, not only are we going to train you to be the best doctor, nurse, physio, exercise, whatever. Not one of them says, oh, and we're going to teach you to practice in a team. Not one of them. It's terrible. So to the students, I say, be sure you understand what your colleague who is in a different professional program is learning, and what is they're going to do, and how it is you're going to interact when you get out there. Because by golly, we're not going to have collaborative, team-based care for the patient if you don't. You've got to know what those people do, and appreciate them for that. So arrange a coffee clutch or go and have a beer or whatever it is you do, but make sure you know what those people are doing before you get out there, because once you get out there, you're going to be put in the chute, and there's no way.
Yeah, it's
Okay.
It's hard to learn while you're in the middle of it, right?
That's right.
So John, thank you so much. I appreciate you taking the time to do this, and I know the students learned a lot from your presentation. So have a wonderful day. I will see you soon, my friend.
Thank you for your attention.
Take care.
My relations. Bye now.
Okay, bye-bye.